Ready? The Subcommittee on Health, Employment and Labor and Pensions will come to order. Welcome, everyone. I note that a quorum is present, so I ask unanimous consent that Mrs. Schreier of Washington and Ms. Davis of California be permitted to participate in today's hearing, with the understanding that their questions will come only after all members of the Subcommittee on Health, Employment, Labor, and Pensions on both sides of the aisle who are present have had an opportunity to question the witnesses. Without objection, so ordered. The subcommittee is meeting today in a hearing to receive testimony on examining surprise billing, protecting patients from financial pain. Pursuant to Committee Rule 7C, opening statements are limited to the chair and the ranking member. This allows us to hear from our witnesses sooner and provides all members with adequate time to ask questions. I recognize myself now for the purpose of making an opening statement. We're here this morning to examine surprise medical billing, a serious issue that can disrupt, if not devastate, the lives of individuals and families. This is the first hearing the United States Congress has held on surprise billing, and I'm proud that our subcommittee is taking the lead on this important issue. It is my hope that this will be the first of many productive bipartisan conversations. Surprise medical bills occur when patients covered by health insurance are subject to higher than expected out-of-pocket costs for care received from a provider who is outside of their plan's network. The victims of surprise medical billing often have no control over whether their medical provider is in or out of network. With one infamous case, a young San Francisco woman named Nina Dang suffered a severe bike accident. She was barely lucid when a bystander called an ambulance and took her to an emergency room at a nearby hospital. Before she knew it, doctors had done x-rays and scans and put her broken arm in a splint and then sent her on her way. A few months later, Nina was hit with a $20,000 medical bill because the hospital, which she did not choose, was an out-of-network facility. But even patients who are able to take precautions to avoid out-of-network costs during a medical emergency are not immune from surprise bills. Scott Cohan suffered a violent attack one night in Austin, Texas. He woke up in an emergency room with a broken jaw, a throbbing headache, and staples in his head. Despite his shock and immense pain, Scott took out his phone and searched through his insurer's website to make sure he was laying in an in-network hospital bed. When he found out it was, he proceeded with the necessary jaw surgery. Imagine Scott's frustration and devastation when he received a surprise medical bill for nearly $8,000. It turned out that the emergency room was in his insurance network, but the oral surgeon who worked in the ER was not. These stories have been documented in details by Vox reporter Sarah Cliff. These are not isolated incidents. According to a survey, 57% of consumers report they have received an unexpected medical bill that they thought would be covered by their insurance. A separate survey found that 7 in 10 patients who have received unaffordable out-of-network medical bills were unaware that their provider was out of network at the time they received the services. This issue requires bold action to protect patients from the financial pain of surprise medical bills. States have taken steps forward by enacting innovative bipartisan billing laws. New York, New Hampshire, Connecticut, New Jersey, Maryland, Illinois, Oregon, California, and my home state of Florida have all adopted strong reforms that protect consumers. Importantly, all of these solutions either hold patients harmless against charges or prohibit the practice of balance billing, where a patient is sent a bill for the difference between what insurance will pay and what the provider charges. We have also seen many states pioneering new ways to resolve billing disputes between providers and insurers in ways that, most importantly, take consumers out of the middle. These state-level solutions are promising, and witnesses today will be able to provide this subcommittee with details on how such efforts are working in states where they may be falling short. However, only Congress can fully close the gaps and loopholes that leave patients vulnerable to severe financial distress. Most Americans live in states that have not passed major reforms regarding surprise bills. And even in states that have enacted reforms, they are unable to regulate self-insured plans, which cover more than 60% of individuals in employer-sponsored coverage. Healthcare has not recently been an area of bipartisan consensus. Unfortunately, that has only been reaffirmed by the administration's actions last week to not defend in court the Affordable Care Act and its protections for people with pre-existing conditions. But I am hopeful that this is an opportunity for us to work together on behalf of our constituents. Surely we can all agree that a patient should not have to spend the last few minutes before emergency surgery researching whether everyone in the operating room is in network. And Dr. Rowe came over to me this morning and said, "I'm so glad that you're having this hearing." I'm grateful to the witnesses for their time and testimony here today, and I look forward to working with my colleagues and with stakeholders as we develop a solution to the challenge of surprise medical billing. Now, I want to recognize Ranking Member Wahlberg for the purpose of an opening statement. The esteemed Representative Wahlberg.
I could get used to that, Madam Chairperson. Thank you. And thank you for this hearing. I think, along with Dr. Rowe and the rest of my subcommittee members, I think we concur that this is an issue we ought to be dealing with. And we shouldn't delay in considering options, even as we stand on this side of the aisle also very strongly supportive of taking care of pre-existing conditions as well. This certainly falls into that area. The high and rising cost of health care is a significant worry for families, workers, and employers across the country. Concerns about high premiums, high deductibles, and drug prices are known and well documented. But the issue of surprise billing has rapidly risen to the forefront of people's worries when it comes to health care. Surprise billing, sometimes called balance billing, happens when a patient visits an out-of-network care facility or even when they are at an in-network care facility but are seen by a doctor who is not in their network. The story of surprise billings may go something like this. A worker who's having trouble breathing visits an emergency room at a hospital in his or her health insurance network. While there, they receive an x-ray of their chest, and it's seen by a doctor who prescribes medicine to ease the strain on the lungs. Following the visit, he or she gets a bill, a high bill, for the trip to the emergency room. Even though the hospital was technically in network, the doctor who saw him was not, leaving him to pay for the cost of treatment. This understandably causes frustration for individuals who thought they did everything correct. It can also cause a high degree of uncertainty and stress for workers and families as they try to find the money to pay for the health care service they believed would be handled by their insurance. According to a 2018 poll from the Kaiser Family Foundation, Surprise medical bills are the leading health care concern for Americans, surpassing concerns about high premiums, high deductibles, and rising drug costs. 39% of insured working-age adults reported they had received a surprise medical bill in the past year from a doctor, hospital, or lab that they thought was covered by their insurance. Of the 39% of individuals who received surprise medical bills, 50% owed more than $500. The fear of an unexpected medical bill can be paralyzing, and we don't want Americans foregoing care they need for fear that they'll end up responsible for medical expenses that they can't afford. We need solutions that equip patients with the information they need to confidently seek treatment without the worry they'll face a huge surprise bill. About 60% of workers, or 110 million individuals, are insured through employer-sponsored health care plans under the Employee Retirement Income Security Act, ERISA. Employer-provided coverage is important to workers around the country. Employers can custom design a health care plan best suited to their workers' needs, which helps them retain their workforce and also an important recruiting tool. I just had a conversation with an employer this morning, a major employer in Detroit, who, as a result of opportunities now, has looked for additional benefits that they can supply for their employee. A 2018 study from AHIP found that over 70% of workers are satisfied with their employer-sponsored coverage. 22 states have laws addressing surprise billing. However, under ERISA, self-insured employer-sponsored plans are only subject to federal rules and protections, and state rules and regulations on health insurance do not apply. Promoting public policy solutions that allow employers to continue offering high-quality health coverage is good for employers and employees alike. That's why we're here today, to listen and learn from a variety of stakeholders about different proposals to address this serious issue. With this in mind, we recognize that any potential federal policy solution to end the practice of surprise billing must preserve important ERISA protections and ensure that self-insured plans remain subject to federal law alone. Committee Republicans are committed to pursuing policies that lower costs, expand choice, and end surprise billing for insured individuals. Workers and families deserve certainty about their health care coverage, and I look forward to discussing how we can provide a better way forward for the American people. Thank you, and I yield back.
Without objection, all other members who wish to insert written statements into the record may do so by submitting them to the committee electronically in Microsoft Word format by 5:00 p.m. on April 16, 2019. I will now introduce our witnesses. Kristen Link Young is a fellow at USC Brookings Schaefer Initiative for Health Policy. Welcome. Elise Schumann is a Senior Vice President for Health Policy at the American Benefits Council. Welcome. Frederick Asasi is the Executive Director of Families USA, a leading voice for healthcare consumers. Thank you. Dr. Jack Hoadley is a research professor emeritus at the McCourt School of Public Policy at Georgetown University. Welcome. We appreciate all of the witnesses for being here today and look forward to your testimony. Let me remind the witnesses that we have read your written statements and they will appear in full in the hearing record. Pursuant to Committee Rule 7D and committee practice, each of you is asked to limit your oral presentation to 5 minutes as a summary of your written statement. Let me also remind the witnesses that pursuant to Title 18 of the U.S. Code, Section 1001, it is illegal to knowingly and willfully falsify any statement representation, writing, document, or material fact presented to Congress, or otherwise conceal or cover up a material fact. Before you begin your testimony, please remember to press the button on the microphone in front of you so that it will turn on and the members can hear you. As you begin to speak, the light in front of you will turn green. After 4 minutes, the light will turn yellow to signal that you have 1 minute remaining. When the light turns red, your 5 minutes have expired, and we ask that you wrap it up. We will let the entire panel make their presentations before we move to member questions. When answering a question, please remember to once again turn your microphone on. I will first recognize Ms. Young.
Thank you. Chairwoman Wilson, Ranking Member Wahlberg, members of the subcommittee, thank you for the opportunity to testify today. I'm Kristen Young, a fellow with the USC Brookings Schaefer Initiative for Health Policy. My testimony today is based on research conducted with a number of talented co-authors and reflects my personal views. Surprise out-of-network bills arise when a consumer receives care from an out-of-network provider in situations that they cannot reasonably control. One common example is an out-of-network anesthesiologist at an in-network hospital. But these bills can arise for many services: emergency department, pathology, and even neonatology. Situations like these, where a patient is treated by an out-of-network provider that she did not choose, are common. Studies suggest that about 20% of emergency department visits and 10% of elective inpatient care stays involve at least one out-of-network provider. And about half of ambulance rides are out-of-network. The bills patients receive under these circumstances can be quite large. The existence of surprise bills and their large sizes reflect a market failure. For most types of physicians, joining insurance company networks is standard because many patients are not willing to bear higher out-of-network costs. But for types of physicians that patients do not choose, this logic doesn't apply. Emergency physicians and anesthesiologists receive a flow of patients based on individuals electing care at the hospital in which they practice, and that volume will be the same regardless of whether the physician is in or out of network. Because volume does not depend on prices set by providers in these no-choice specialties, going out of network frees them to bill patients at essentially any rate they choose. And as would be expected, we see that physician specialties that are able to bill out of network have an extraordinarily high charges compared to other doctors. For example, for most physician types, median out-of-network charges are about double what Medicare pays for the same service. But for anesthesiologists and emergency medicine physicians, charges are about 5 times greater than the equivalent Medicare payment. To be sure, many of these providers do still choose to join insurance networks. That may be because they find it distasteful to bill patients directly, or they prefer the ease of collecting from insurers. But when they do go in-network, they appear to receive some of the highest in-network rates in the healthcare industry. Whereas the in-network payment across many similar specialties averages about 125% of the Medicare payment rate for the service, the available data suggests that the average in-network rate for anesthesiologists and emergency medicine physicians is roughly 3 times the Medicare rate. One way to understand these very high in-network rates is that these physician types exploit the fact that they could remain out of network to demand very high payment rates when they do go in-network. Payment rates more than double what their peer physicians who cannot stay out of network receive. And the impact is felt broadly by consumers of healthcare. Sometimes out-of-network care generates an eye-popping surprise bill that ends up in the news. But in many other cases, the insurer agrees to pay the very high charge, and this, along with high in-network rates, drives up healthcare premiums for all of us. Policymakers who want to solve this problem need to correct the market failure and create an environment where these providers face a more typical set of incentives. There are 2 basic ways to approach the solution. The first is to establish an amount that these physicians will be paid when they deliver care out of network. Policymakers should establish the out-of-network price for the service, either directly or through arbitration, prohibit balance billing by the provider above this amount, and require that the insurer treat it as in-network. The goal is not to establish the exactly correct payment rate for the service, but rather to establish conditions that diminish the attractiveness of the out-of-network option and lead these providers to go in-network or work with hospitals to get paid a fair rate for the service. While there are a number of methods that can be used to establish the out-of-network price, It is critical that it not be set at a rate that is too high, either higher than now or that locks in the current distorted market, since that would drive up costs and frustrate the basic goal of restoring a market for these services. The second approach is to get these providers out of the business of billing directly to patients or issuers at all. Instead, they would be paid by the hospital or the facility in which they practice. Hospitals would negotiate with insurers for a rate that includes the services, and hospitals would pay the anesthesiologist or other facility-based providers. An alternative version would require that facility-based providers establish contracts with all insurers that are in network for the facility. Before I close, I want to briefly highlight the work states are already doing. Many states have taken steps to correct the market failure by pursuing a diverse array of policies. But states are somewhat limited in their ability to act comprehensively by the threat of ERISA preemption, and they face challenging border state issues. Thank you. I look forward to your questions.
Thank you, Ms. Young. We will now recognize Ms. Schuman.
Chairwoman Wilson, Ranking Member Wahlberg, and distinguished subcommittee members, thank you for the opportunity to testify on behalf of the American Benefits Council about the growing problem of surprise medical billing. The Council applauds your willingness to examine and consider federal solutions to protect patients from the financial pain of these surprise medical bills. Collectively, our members directly sponsor or administer health benefits for virtually all Americans covered by employer-sponsored plans. Employers are deeply concerned about the burden that unexpected medical bills from out-of-network providers place on employers and their families. While a number of states have sought to address this problem, ERISA exempts self-insured plans from state insurance regulations to ensure that national employers can offer uniform health benefits to employees residing in different states. Accordingly, the problem of surprise billing cannot be left to the states to solve. Indeed, we view the effort to protect patients from surprise bills within the broader context of efforts to lower health care costs. A lack of meaningful patient choice between providers who participate in a plan's network and those who don't is the key component of surprise balance billing. In the case of emergency services provided at out-of-network facilities and air ambulance service, the patient simply needs the most expeditious stabilizing care. Even when patients seek care at an in-network hospital from in-network providers, patients generally lack a role in choosing ancillary but necessary physician like an anesthesiologist. On the day of surgery, is a patient really going to question the network status of the anesthesiologist? A study comparing physician charge to Medicare payment ratios across specialty sheds light on the drivers of surprise billing. Physician excess charge was higher for specialties in which patients have fewer opportunities to choose a physician or be informed of the physician's network status. For example, anesthesiologists were charging more than 5 times as high as the Medicare rate. The ability of such specialties to set billing rates in this environment serves as a powerful incentive to remain out of network, which in turn generates surprise balance bills. Clearly, this constitutes market failure, which necessitates legislative or regulatory intervention. Health plan networks play a critical role in employer efforts to lower the cost and improve the quality of health care for employees and their families. They're the best tool employers have to drive better health care value. Despite the efforts of employers to prevent unexpected balance billing or help employees faced with such a bill, the underlying problem continues. We urge Congress to develop legislation addressing surprise balance billing that protects patients without undermining access to high-quality, high-value networks. One council member company with 130,000 covered lives estimates that without networks, premiums would increase by approximately $8,000, a 45% increase. The council is also concerned that a requirement for payment by employer-sponsored plans to providers in excess of in-network rates or by reference to billed charges would discourage network participation and drive health care costs higher. Shifting the costs to payers merely masks the underlying problem of a distorted market. We also have concerns with federal legislation mandating binding arbitration. It would be costly, complex, and time-consuming for nationwide employers. If federal legislation does require the use of binding arbitration, policymakers should include sufficient protections to guard against increasing health care costs. We offer the following recommendations for federal legislation addressing the problem of surprise billing at its root and in a nationally uniform manner. The message I'm delivering is reflected in a letter sent to you from over 30 trade associations. Number one, protect patient from surprise medical bills. Number two, hospitals and physicians must provide upfront information about out-of-network care and cost. Number three, require certain reimbursement. To ensure equitable payment for services provided without discouraging network participation, federal legislation should establish a cap for emergency services at an out-of-network facility at 125% of the Medicare rate, which would be clear and facilitate competition. Legislation should also require all in-network providers, all at an in-network facility, to accept in-network rates. When a plan contracts with a hospital, it stands to reason that all essential services performed at the hospital would be included in the network. Requiring in-network facilities to bundle medical services for covered procedures into a single payment could also help the problem if structured properly. Legislation must also address ambulance services. The Council looks forward to working together on a solution that cures this problem, not merely masks its symptoms. I'm happy to answer any questions. Thank you.
Thank you. We will now recognize Mr. Isasi.
Thank you very much, Chairwoman Wilson and Ranking Members Wahlberg and members of the subcommittee. Thank you for the opportunity to speak with you today. I'm Frederick Isasi, the Executive Director of Families USA. For nearly 40 years, we have served as one of the leading national voices for healthcare consumers, both in DC and on the state level. Our mission is to ensure that every individual live to their greatest potential by ensuring that the best health and healthcare are equally accessible and affordable to all. Surprise out-of-network medical bills are a truly egregious and all too frequent example of how distorted economic incentives in the healthcare sector are overwhelming the interests of patients and families. A whopping 1 in 5 emergency department visits results in surprise medical bills. These bills can amount to hundreds, thousands, and even tens of thousands of dollars. This is an utterly nonpartisan issue affecting people across the country in both rural and urban areas. Given this committee's jurisdiction, it's critical to note that self-insured, as we've heard today, self-insured ERISA health plans are as likely to experience surprise billing as fully insured and individual plans. So what's most important to remember about this issue? We are talking about situations in which families, despite enrolling in health insurance, paying their premiums, doing their homework, and trying to work within the system, are being left with completely unanticipated and sometimes financially devastating health care bills. And this is happening in part, and I want to say this really clearly, because hospitals, doctors, and insurers are washing their hands of their patients' interest. Take, for example, one significant driver of this problem, the movement of hospitals to offload staffing requirements for their emergency departments to third-party management companies. These hospitals very often make no requirements of these companies to ensure the staffing of the ED fit within the insurance networks that the hospitals have agreed to. As a result, a patient who does their homework ahead of time and rightly thinks they're going to an in-network hospital receives services from an out-of-network physician, and a surprise medical bill follows. Let me give you one real-world example. Nicole Briggs from Morrison, Colorado, outside of Denver. Nicole woke up in the middle of the night with intense stomach pain. She went to a freestanding ER. She was told she needed an emergency appendectomy. She went to her local hospital. She did her due diligence, confirmed repeatedly that the hospital and its providers were in network. However, months later, she received a surprise bill from the surgeon, who ended up was out of network. The bill to Nicole was $5,000. Nicole tried to work it out with her insurance company, but within 2 years, a collection agency representing the surgeon took her to court and won the full amount, including interest. As a result, a lien was placed in her home, and the collection agency garnished her wages each month. This came right before Nicole was about to deliver a baby and go on maternity leave. And by the way, this investigation found that there were over 170 liens placed on people's homes in the Denver area by emergency department physicians. And this is just one example. Consumers are exposed to surprise medical bills in other ways. Often, as we've heard, ground and air ambulances are out of network. And many ancillary services like anesthesiology, laboratory services, imaging services can be out of network despite the fact that the facility and the physician that's supervising are all in network. This is inexcusable behavior on the part of hospitals, doctors, and health insurers. They each know or should know that patients have no real way of understanding the financial trap they've just walked into. In these surprise bill instances, it is the providers and insurers, not the patients, who should bear the burden of settling on a fair payment. Nicole and millions of families around this nation need you to act. They are paying their premiums, trying to do their due diligence and operate within the system, but the current system is leaving them financially vulnerable and destabilized. To put the needs of families first, we built a coalition and developed 5 key principles for legislative action by Congress to address surprise medical bills. The first, and we've heard this from, I think, from the whole panel so far, providers should be prohibited from billing for surprise out-of-network services, and these protections should trigger automatically without consumers having to jump over hurdles. Second, it should prevent surprise out-of-network payments from increasing health insurance premiums. That's really important. Consumers care about their premiums too. Third, legislation should apply protections to all commercial health insurance plans, including ERISA plans that this committee has jurisdiction over. Fourth, protection should apply to all care settings and care types where families can receive out-of-network bills due to no fault of their own. And finally, we are very supportive of increased transparency in the healthcare sector. We fight for it all the time, but we underscore in this instance, increased transparency cannot be the only or main strategy to deal with this problem. So we're grateful for being able to testify to the subcommittee. I'd be very happy to talk about those principles more or answer any questions.
Sassi. We will now recognize Dr. Hoadley.
Thank you, Chairwoman Wilson, Ranking Member Wahlberg, and members of the subcommittee. I do appreciate the opportunity to share my perspectives about surprise medical bills. I'm Jack Hoadley. On the research faculty at Georgetown University, and I'm going to draw today on a 50-state study of state laws and regulatory activity that I've conducted along with my colleagues at Georgetown. We've also taken a more in-depth look at some of these particular state protections. As you've heard already today, patients often receive surprise medical bills when they have reason to assume they're being treated by network providers or when they have no real ability to select a network provider. Many Americans are worried that they may confront a surprise bill of this type, and it happens all too often, and you've heard the examples already. Our research shows that to date, 25 states have acted to protect consumers from surprise bills in at least some circumstances. 9 of these 25 meet our standards as offering what we consider to be comprehensive protection. For protections to be comprehensive, we look to, number one, whether they apply in both emergency situations and in in-network hospital settings, such as electing an in-network surgeon but being treated by another clinician who's out of network. Second, that these laws apply to both HMOs, PPOs, and all other types of insurance. Third, that the laws address both insurers by requiring them to hold consumers harmless from balance bills and providers by barring them from sending balance bills. And fourth, that the laws adopt some kind of a payment standard, either a rule to determine payment from insurer to provider or an arbitration process to resolve payment disputes. Although these 4 conditions don't guarantee complete protection for consumers, they combine to protect consumers in most emergency and network hospital settings that the states can address. But as you've already heard, state protections are limited by federal law ERISA, which exempts from state regulations self-insured employer-sponsored plans. Although many of the state laws have been in effect only a short time, we can learn some key lessons from the state experiences. First, it's critical to consider whether consumers are protected regardless of the type of provider. Some state laws limit their protections to hospital-based physicians, such as anesthesiologists or emergency department physicians, but consumers may also face surprise bills when treated by other specialists who are called in for their particular health needs, such as a neonatologist, a cardiologist, or a gastroenterologist. And some state laws do not offer protections when services are delivered in out-of-network hospitals, but only cover situations where you're in the in-network hospital but are treated by an out-of-network provider. In addition, most state laws have not addressed ground ambulance transportation, and states are prevented by the Federal Airline Deregulation Act from addressing air ambulance providers, so those are also gaps. Second, Some state laws apply only to HMO enrollees and not to PPO enrollees, and this limits the scope of consumers protected. But of course, the larger gap, as I've already mentioned, is the ERISA plans. New Jersey and New York have explored voluntary approaches for ERISA plans, but it's too early to tell if these will have any impact, and they are only voluntary steps. Third, some states have considered making protections contingent on whether consumers receive a disclosure about the possibility of surprise bills. And although disclosure is helpful for consumers, making protection contingent on those disclosures seems inadequate given the challenge that consumers already face in understanding the many disclosures they see at a medical encounter. You go into the medical system, you get a whole clipboard full of pieces of paper you're supposed to read and sign, and if this is just one more of those, it doesn't really help. Fourth, determining how to set a payment rate for the services delivered by a non-network provider may be the most challenging issue, as we've already heard some comments on. Some states set a payment standard for what the insurer must pay, but states differ in whether to base the standard on Medicare rates, on average network rates, or on provider charges. And there are advantages and disadvantages to each of these. For example, basing payment on provider charges will tend to drive up costs. Other states have elected an arbitration process to determine a reasonable reimbursement for a particular case. Arbitration is typically designed in a way that encourages providers and insurers to reach a voluntary agreement and leave the arbitration as a last resort. And the last lesson is the challenge of enforcement. States have more ability to regulate insurers than providers, and that can be an issue. But the key is to avoid placing the onus on the consumer to protest a surprise bill. Although states are making progress in protecting consumers from surprise medical bills, they're looking to the federal government to address the self-insured ERISA arrangements they cannot regulate. Federal legislation would also help consumers in the many states that have not yet acted. In addition, state officials have noted that a federal law could help when a state resident receives care across the border in another state. But questions remain on what role states should continue to play if there is a federal law. For example, does that federal law defer to existing state laws or leave a role for states to adapt rules to local market environments? The key unifying principle for states has been that consumers should not be liable for surprise medical bills in these circumstances we're talking about. Protecting consumers in these situations will offer them some relief from worry about health costs. Thank you.
Thank you. Thank you, Dr. Hoadley. We will now proceed to member questions. Under Committee Rule 8A, we will now question witnesses under the 5-minute rule. I will now yield myself 5 minutes. First of all, let me thank you for the very interesting testimony. When we talk about surprise billing, it seems that a fundamental problem facing consumers is they often have no way of knowing whether their provider is in the plan's network. And it is unclear to me who has the burden of making sure that the consumers have the information they need in order to make an informed decision. So I'm going to ask Mr. Isasi, under current law, who is responsible for making sure that a doctor or hospital is in network? Is it the doctor, the insurance company, or the patient themselves?
Chairwoman Wilson, thank you for the question. To be very clear, it is the patient themselves that has that responsibility. And these negotiations are very complex. These are some of the most important and intense negotiations in the healthcare sector between a payer and a provider. There is absolutely no visibility for a consumer to understand what's going on there. And so the notion that a consumer would walk into an emergency department and know, for example, that their doctor was out of network because that hospital could not reach agreement on an in-network provider for the ED is absurd. Right? There's no way they would ever know that. And similarly, if you walk in and you receive surgery and it turns out your anesthesiologist isn't in network, there's no way for the consumer to know that. And I'd like to say there's some discussion about transparency and creating, sort of provider directories. We've tried to do that in many instances. And what we know is that right now the healthcare sector has no real way to provide real, actionable insight to consumers about who's in network, who's out of network. I would posit probably everybody in this room has tried at some point to figure out if a doctor's in network and out of network, and as we know, that system doesn't work. So this idea that consumers can do research and find out what's happened behind the scenes in these very intensive negotiations is absurd, and it doesn't work.
Okay, let me follow up. The burden in non-emergency situations is also significant. Would any of the witnesses like to comment on this issue? In elective procedures, do patients always know the name of all of the doctors who could potentially be sending them a bill later? Anyone?
I'd be happy to talk about that. And the answer, again, is no. And there is no obligation on the part of those providers to provide that kind of notice to a patient about the kind of care they're going to be getting, who's it from, and whether they're in-network or out-of-network, and what the cost associated with that is. Therefore, I do think that rules requiring some disclosure up front at the time of scheduling, when you can actually make a difference, would be helpful. But as the other witnesses pointed out here, increased notice and transparency is only part of the problem.
But even if a patient is able to determine the name of every doctor that will see them, I worry that not all of the information they're given about their network is accurate. Dr. Hoadley and or Mr. Asasi, would you comment on the accuracy of provider directories? What happens if a consumer relies in good faith on inaccurate information about their plan's network? Because it changes.
Yeah, that's a really good point. Provider directories can be notoriously inaccurate. One of the things that, even if they are accurate, that I've seen in my own family is you may be enrolled in Blue Cross, you ask your physician, are they participating in Blue Cross? They say yes, but it turns out Blue Cross has a variety of different networks. This would be true of any insurance company. And so, you may be in this one particular flavor of the Blue Cross plan, and your provider may not participate in that particular network. So it's a very complex issue, and some of the states have tried to link protections for balanced billing with some of the issues around adequate networks and adequate provider directories.
Okay, this Ms. Young, why is it important providing an appropriate federal payment standard, whether by establishing a benchmark or creating a dispute resolution process? Why is that necessary to address this problem of surprise billing?
Absolutely. So as my co-panelists have talked about, notice isn't enough here. Even if a consumer had perfect information, which is not a reasonable expectation, but even if they did have perfect information, they can't do anything with that information. They can't go across town to get their anesthesia and then come back to the hospital. They're even with perfect information, they may be treated by out-of-network providers, and so we need to set a standard that limits how much providers can be paid in these out-of-network scenarios, that makes it sort of less attractive for providers to remain out-of-network, and so instead they are subject to more normal market conditions.
Thank you so much. I now recognize Ranking Member Wahlberg for his round of questions.
Thank you, Madam Chairwoman, and thank you for the panel for being here. Ms. Schuman, we've had this hearing specifically because of the rise, at least the ability to see the number of surprise billings that have taken place and balance billings that are going on, and the escalation there and the problems. What factors could you suggest that have led to the rise in occurrence of these surprise billings, and do you think the trend will continue if action isn't taken?
Yes, well, thank you for the question. And all of these cases of surprise billing have a common theme. The patient lacks a meaningful role in choosing between a provider who's in the network or outside of the network. And the provider is not bound by competitive market forces to join or not join that network. So the real problem fueling surprise billing is that, for example, hospital-based specialists like anesthesiologists or radiologists or emergency physicians don't have to lower their prices to draw patients. They can charge higher rates and the patients will still come. So with these automatic referral of patients, the typical price-volume trade-off for joining a network does not apply. Again, this is a fundamental market failure that I believe will only worsen if action is not taken to restore competition and choice.
We've talked about already in the initial questioning about transparency, adequacy of information. It just isn't there. Even if it were, are patients and their loved ones capable of navigating these types of decisions about their health care under difficult circumstances?
Well, I think any one of us who've been in this situation, either ourselves or with our family members, know how challenging that is. And patients and loved ones should not be put in the position or expected in a stressful emergency circumstance to be able to understand and navigate all the complexities of our healthcare system. In these instances, our laws should go beyond just the mere notice of a provider's network status to protect individuals against costly surprises when they are in no position to direct their care themselves.
List a few mechanisms or approaches for patients, I guess we could say ratepayers, insurance ratepayers as well, to protect themselves against that surprise billing experience.
Well, I laid out some of the recommendations, and to reiterate, I think it has to start again with protection of the patient and a ban on the practice. But beyond that, we really do need to address this in a uniform way to make sure that we capture the 60% of ERISA self-funded plans, and also one that is directed at the root of the problem, which I just described. And so therefore, we need to remove those incentives that encourage these out-of-network providers to stay out-of-network, while at the same time ensure that they're equitably compensated for our services. So in the case of an out-of-network hospital or facility performing emergency services, I suggest that a Medicare rate of 125%, it's clear and a way to restore competition and negotiation with respect to that out-of-network facility for emergency services. For in-network hospitals, when a plan has contracted with that in-network hospital, all of the providers practicing at that hospital should be paid no more than an in-network rate. When you buy a car, you assume that the steering wheel and the tires are going to be attached. And I think it's somewhat similar to that. I think there's also been a discussion about a bundled payment model whereby the hospital submits one single bill. And that might have some merit, again, but if there's appropriate safeguards on there to prevent against price escalation or undermining employer plan networks, which are the greatest tool that employers have to both reduce the cost of health care and increase the quality.
Just for the, I'm going to run out of time, so I won't do this to you. If you could just briefly discuss the price difference between in-network rates and out-of-network rates.
Sure, happy to. And I think what we've seen is in-network rates or out-of-network rates more than 2 or 3 times in-network rates, depending upon, again, certain specialties. And I think we've also seen a trend, a recent report about the fact that that gap is growing and that it's alarming. It's not in comparison to costs, and it's not in comparison to networks. And I think as that trend continues and that gap continues to grow, we want to address this situation in a way that narrows that gap, not only makes it wider.
Thank you, and thanks for the grace period. I yield back.
We will now hear from the distinguished chairman of the Education and Labor Committee. Mr. Scott, welcome.
Thank you, Madam Chair. Ms. Young, Section 1311E3 of the Affordable Care Act helped improve transparency by requiring plans to provide public and timely disclosure of certain information. Why is this section important, and what's the status of the implementation?
Thank you for the question. I think as we've talked about, transparency is important. It's not a comprehensive solution to this problem, but it is important to give consumers information about their healthcare services. The Federal Department of Health and Human Services has taken some steps to require disclosure of basic information about health plan information for qualified health plans under 1311E of the Affordable Care Act. Those rules have been in place for a couple of years, and I think we have the sort of first year of data has become publicly available just over the last 6 months or so.
How useful is that information, and is the Department of Labor doing its job under the provisions of the Act?
So I don't think the information under Section 1311E is particularly useful for consumers that are trying to navigate the out-of-network situation, though it does provide us some insight about what is going on in health plan networks, and I think researchers certainly welcome that transparency. For the Department of Labor, so there's a parallel requirement that group health plans make information available. My understanding is that the Department of Labor proposed some standards about updating sort of the tax form that ERISA plans file to include better information about health plans, but that those policies have not been implemented and are not in effect.
Now, we've had a lot of back and forth about what doctors can charge. Why doesn't normal contract law apply? The doctor can't charge what he or she wants. When you go into the hospital and receive the services, you have, under contract law, agreed to pay a reasonable fee, not whatever the doctor thinks he can get out of you. Why isn't what they accept under Medicare, what other physicians similarly situated accept, why isn't there some more reasonable calculation of what the physician is owed, not just what he wants, 2, 3, 4, 5 times what Medicare pays? I mean, there's a contract law.
Yeah, so this is, I think, an interesting area of the law. Right now, when patients are seen out of network, the providers are sending them balance bills at a rate that, as you suggest, the provider has sort of largely made up. It's not determined by market forces. There are some legal scholars who have been advancing this idea that there's no contract between the patient and the anesthesiologist in this circumstance. And so as a result, there sort of hasn't been a meeting of the minds, and so we fall back on background contract law principles that would limit how much the anesthesiologist gets paid. And there have been a couple of cases across the country that try to test this theory. I'm not an expert in these cases. I don't think any of them have been successful yet, but it is an interesting area of legal inquiry.
I don't know who this should be aimed at, but there's another surprise bill when you go in for a screening, and which is supposed to be free under the Affordable Care Act, and they do some little procedure in the middle of it. It converts the whole thing into a treatment, which is not free under the Affordable Care Act. Is that not a surprise in addition to the other surprises we're getting?
So I can talk a little bit about that issue. As you note, it's not the same problem as the surprise balance billing that we've been talking about, but consumers who are receiving free preventive care under the Affordable Care Act an example is a colonoscopy where the individual sort of starts with a screening colonoscopy and ends up getting a biopsy or a polyp removal.
And then you have to pay for the whole thing.
And that can generate charges. My understanding...
About what kind of charge are we talking about?
It will depend on the procedure, but it can be fairly expensive it's an invasive outpatient procedure, so it can be expensive. The Department of Labor, HHS, and Treasury have issued guidance that tries to limit that practice for colonoscopies performed in employer coverage, but my understanding is this is still a problem in the Medicare context.
Anybody else want to comment on that?
I would simply note that it's an example of a broader issue that is what we're talking about here, which is a lot of situations you go in for one particular procedure, you're doing an elective procedure, but something else arises. So you might be going in for your knee replacement, but something happens while you're in the middle of that surgery and your heart's not doing the right thing, so they bring in a consulting cardiologist. And that could turn out to be one of these out-of-network situations. So, healthcare is not so predictable. We can't assume that simply because you went in to do X, a screening colonoscopy, a knee replacement, that isn't going to trigger some other problem. And then that's part of what we're trying to address in these issues.
Thank you, Mr. Scott. Dr. Rowe?
Thank the chair, and I want to thank the chair for having this very important hearing and all the members for being here. And Dr. Hoadley, I was reading your, what's a surprise medical bill? Is any bill sent by a medical provider to a patient for an amount larger than expected. I think all the bills I ever sent to patients thought they were larger than they expected, so probably applies to everything. I really appreciate you being here, and Ms. Sherman, you make a point about a car. The difference in healthcare, though, is you go down to your car dealer and you buy a car, he doesn't have to send you out without a car unless you pay for it. There's a law passed, and as it should have been, in 1986 called EMTALA. You're very familiar with it. And we have to cover anyone who comes into an emergency room that sees a Medicare patient, as we should. I'm an obstetrician by training, and I've done that many, many times before. And so what happens to us on the provider side is that we have to provide those services as we should, regardless of your ability to pay. So we have that restriction on us, as we should in the hospital. I've been negotiated out of healthcare networks, our group, which was a large group. So there are no innocents in this. When you look at the insurers, the hospitals, the providers, everybody's culpable here. And I could not agree more about transparency. I've had a surprise bill after a surgery I had a year and a half ago. So I'm very much aware of that, and I could negotiate it because I knew the nuances of this. Many people cannot. It is complicated. And even, Dr. Hoadley, as you said, even having, I've had my name in networks that I wasn't in, that you use, and many of those unscrupulous networks will use that to get people to sign up because this doctor, my doctor, is in there when you're really not, and you get surprised bills. So another couple of things I want to mention is that we have to look at. When you look at Medicare, for instance, as a benchmark, and most of us don't have a problem with that, except if you look at the Medicare wage index. Where I live in rural Tennessee, we have the second lowest Medicare wage index in the United States. We get 0.73 cents for what someone else gets $1 for. Now, in California, for instance, they have a very, very generous Medicare wage index. So we pay our providers less, and we can keep less than 10% of the nurses that we actually train in our area because we can't pay them enough. So when you benchmark off Medicare, you're just, again, where we live, you're discriminating against us. And so we need to work that out, and it is a very unfair system that needs to be fixed. And one other buzz I've got a burr up my saddle is in Medicare, if I saw an elderly patient that had a very limited income and I wanted to waive her copay, it is illegal for me to do that. And yet in California, it is illegal for a doctor to balance bills. You got it's a dichotomy. So how do we do all this and put this together where it's fair to the patients and it's also fair to the providers? And one other thing, and anybody can comment on this, we have one hospital system where I live now. They've merged. So there is no competition. There's one. And when you have a bundle payment where that goes just to the hospital, what leverage does a provider have to be treated fairly?
Can I just comment on that? And thank you so much for saying that. I think that all stakeholders have to be part of this solution, without a doubt. And I think to that, to that point, I think it's very important that all stakeholders, again, are part of the solution. And we are looking at this in the broader context of the effort to increase transparency and lower healthcare costs. And I think one of the big drivers behind rising healthcare costs is that lack of competition that you talked about. So we really do have a unique opportunity to try to address the root of this problem and the lack of competition that's driving it more.
And to the chairman's point a minute ago, let me tell you how frustrating it is as a provider. I'm doing a procedure, let's say a colonoscopy on a patient, and you're doing a Medicare patient, and you see the polyp that's there. If you take it out, that's a second. I mean, are you going to stop and bring that patient back? Well, I think that's awful to have a patient go through all of that again. And so, as I said, there are no innocents here. I really appreciate just the start of having this discussion. We need to stop surprise billing, no question about that, and do it fairly for everyone. I yield back.
Thank you, Dr. Rowe. And now, Ms. Wild, Pennsylvania.
Thank you, Madam Chairwoman. Thank you all for being here. I'm somewhat gratified by the fact that it seems that we have bipartisan consensus that the surprise billing really is a genuine problem and that patients are the ones who really are the losers in this system. I'm struck by the fact that we all seem to be wanting a solution to this problem. But the solutions that I'm hearing don't really sound very workable in the context of our present medical system. And that's where I really struggle to understand how we are going to fix this. Ms. Schumann made the comment that all stakeholders have to be a part of this, and I agree with you. The problem is that the ultimate stakeholder is the patient, and the patient has no part in this in terms of negotiation or even understanding the complexity of the insurance market and who may be in network or out of network. I will tell you, as somebody with a postgraduate degree who's worked as a lawyer in the insurance field for many, many years, I never understand a hospital bill without calling and seeking answers. And that's coming from somebody who's educated, literate, and knows the field, and I still have a tremendous problem with it. Ms. Schumann, you also used the phrase, and I think what you said was that we need more competition in choice. Was that your statement?
Yes, that was.
And what does that mean?
That means I think that Dr. Rowe was talking about the fact that there was only one hospital in town, and when you only have one hospital in town, it's sort of difficult to negotiate. And I think that again was what I was getting to, both specifically with respect to having more than one hospital in an area, but also more specifically when we're talking about surprise billing and the fact that some of these specialties have this free flow of patients that are coming to them without having to compete on prices and quality to attract them.
I'm sorry, I've just never found that competition causes any sort of clarity when it comes to medical charges. If I develop a relationship with a physician, I continue to go see that physician because I have a level of comfort with him or her. If I happen to be in a district with two excellent regional medical centers, there is plenty of competition in my district, but that hasn't done anything to drive the prices down. And I guess my question to you is, isn't the real problem that we've turned over our medical system to private market forces?
Well, I think that indeed those private market forces are the best lever to drive healthcare value, drive down costs, and increase quality. And that's why I cited an example of an employer member of ours, one of our member companies, who because of networks, basically they're saving their employees and their families 45% than without networks. So I think that networks and high value, high quality, lower cost networks are the key to innovation and to be able to get better value, better cost, and better quality.
But using your reasoning, a patient in New York City, which has a wealth of hospitals and physicians and insurance plans, should result in no patients having surprise billing. And yet, I am quite certain that there are plenty of New Yorkers who have surprise billing every single day. So I come back to my question of, I'm really not convinced that private market forces and competition in choice is the solution here.
Well, I think I also said that there is a fundamental market failure right now. And I think that that's what we're looking for, some sort of national response to this that restores those fundamentals so the market can work, because when the market can work, it works best. But there needs to be assistance and intervention to make that market work.
Well, Mr. Rowe used the expression, there are no innocents here, and I would agree with him, except to say that I think the patients are the innocents. And so there is an innocent party here. Mr. Isasi, you seem to want to say something, so please.
I was going to say, I think there's so many of your observations that we would agree with, but in particular, you're saying, what is the workable solution here? I can't see the constructive, how do we move the ball forward? And what I would say is, there is a concept here, which is, what does in-network mean, right? When you sit down with your husband or your partner and decide, what kind of insurance do we want for our kids, right? We want to make sure that they can go to the ED, if they're playing soccer, they get hurt, all those sorts of things. The question is, when you make that decision and you say, oh, look, this hospital is in network, right? But what does that mean? If you can go to that hospital and all the services they're providing are out of network, right? And I think as you've said and as we've heard from other folks, the patient is not the person who should be responsible for that. It's the folks who are negotiating. It's the hospital, it's the docs, and the payers that should bear that responsibility. So let's start by clarifying what does in-network mean so that we have some way of making educated decisions about the insurance that we're purchasing and putting our trust in.
Thank you. Thank you so much. And now we'll hear from Mr. Meeser.
Thank you, Madam Chair, for holding this hearing and allowing members and staff to learn more about the issues of surprise billing. Thank you certainly to our witnesses for sharing your expertise. I have, and I'd venture to guess many of my colleagues, if not all, have heard stories from distraught constituents about what is very appropriately named surprise billing, where they go for an emergency visit or often a scheduled planned medical procedure or surgery which goes according to plan and then receives a surprise bill, often in the tens of thousands of dollars. So, Ms. Schuman, let's walk through a scenario, please. And I've heard from individuals who have experienced similar scenarios firsthand. At the advice of a doctor, an individual schedules a surgery and confirms that the hospital is in network. The surgery is scheduled 8 weeks in advance, and the individual assumes that there will be no issues with undergoing surgery in an in-network hospital. Only after the surgery does the individual learn that the surgeon was out of network, the primary surgeon, mind you, and receives a bill for $25,000. Had the individual known the surgeon was out of network, they would have very likely found an in-network surgeon. Doesn't that sound reasonable?
Absolutely.
Okay.
And I think that exactly the situation when the patient is doing their homework, they're doing their research. How were they to expect that some of those other services would be out of network?
Okay. Well, what would the patient, what do you recommend that the patient do differently? Ask further questions?
Well, I think in this kind of situation, the patient did everything that they could be doing. And the problem is not the patient. The problem is not the consumer. The problem is that the consumer didn't have knowledge and didn't have a choice. And again, in some situations, even when they have knowledge up front and they are informed of that, they still may not have choices. So I think it's knowledge and choice that the consumer needs.
Well, choice would be understandable. Mm-hmm. Knowledge, not so much. What about the hospital? Do you feel they had any responsibility here in this scenario?
Absolutely. Hospitals play a critical role in this. When you go to a hospital, again, they have the leverage, they have the ability to negotiate with those physicians that are practicing in their hospital. Getting back to something from my testimony, it stands to reason that when you contract with a hospital, all of those essential services that are performed in the hospital under that roof, like anesthesiology or radiologists, would be in network. How can you go to a hospital, how can you have surgery without anesthesiology, or a hospital operate without radiologists?
So you also feel the surgeon in that scenario would have responsibility, or would it be the hospital?
Absolutely. And I think getting back to this point, everyone has a stake in this. All of the stakeholders have a role to play.
Okay. So what would you offer that could be done during that 8-week period leading up to the surgery to help assure that the patient would not receive a surprise bill?
Well, I think we have to look at this in a comprehensive way. And I think, again, we talked about transparency, upfront disclosure. So at the time of scheduling, not when they get into the surgery room, to be able to make a decision based upon their action. But even that alone is not enough. And I think what we have to talk about is getting behind the reason why the patients might have a meaningful choice or might not even know. And that's why I think a federal standard or federal solution that does not discourage these out-of-network specialists to stay out of network and generate these surprise bills in the first place is the core of the solution.
Okay, thank you. Madam Chair, I yield back the remainder of my time.
Thank you, Mr. Meeser. And now, McBath? Okay. Ms. McBath, welcome.
Thank you, Madam Chairwoman, excuse me, for holding this important hearing today. And I've been hearing about surprise medical bills from constituents in my district and from many stories in the news, and like I'm sure that we all have. The recent statistics have been alarming, to say the least. I will tell you, I'm a 2-time breast cancer survivor. I've had many surgeries in my time, and I can tell you the number of times I was surprised myself by these surprise bills that came in unexpectedly. A recent Kaiser Health survey shows that 2/3 of Americans are very worried or somewhat worried that they or a family member will receive a surprise medical bill. In another survey, we see that 57% of American adults have been surprised by a medical bill for something that they expected to be covered by their health insurance. Now, I have here a whole number of individuals just within Georgia alone, and I'm sure there'll be millions more, that represent just these very things that have happened, these surprise bills. These Americans, they are our friends. They're our neighbors and our family members. And I brought these stories from individuals in my district who have been affected by these surprise bills. There's Michelle from Alpharetta, and then also there's Tom from Johns Creek, Elaine from Roswell, and countless others. Like other Americans across the country, they were taken by surprise by a medical bill. These men and women are worried about the financial impact that these bills have on themselves and their families. Some are able to get their bills reduced, but most aren't, and most aren't that lucky. Now, for me, these stories make it clear that we've got to do something at the federal level to address the financial impacts and emotional distress these surprise medical bills have on patients. Mr. Asachi, I'd like to ask you, and thank you for your testimony, as Sarah Cliff of Vox and others have extensively documented, surprise medical bills lead to devastating consequences for consumers throughout our country. Now, I really like evidence and data. And could you talk about what data exists that could help us here in this room and in Congress understand just how large these expenses can be for consumers?
Absolutely. So as we've heard today, there's a few facts. One, almost a fifth of all emergency department visits involve surprise bills. Right? So for all of us, if, as I was saying earlier, if your kid gets hurt playing soccer and you go to an ED, there's a really good chance you're going to get a surprise bill. As you mentioned, we know that right now, almost half Americans, healthcare costs are top of mind, and they report that they cannot meet their basic healthcare needs because the costs are too high. They won't go see a doctor, they won't get their meds because they can't afford it. And 1/3 of people in this country right now are saying that their basic needs of life, their rent, their heat, their food, they cannot pay for those things because of healthcare costs. So this question of surprise billing is falling into a much larger context, which is that American families are overwhelmed by healthcare costs. And surprise bills are just that moment where, despite trying everything, paying your premiums, checking to see if you're in network, right? You find out, now I owe $5,000, $10,000. And what we know, as we've heard, is those bills typically are about 3 times more than they would be paying in network, but they can be tens of thousands of dollars more. Because, as we've heard, there isn't a structured contract between that patient and that doctor, and therefore they can charge whatever they can get away with, right? So I would say that, to your question, one of the most important concepts here is, and we've heard this, and I actually, in a previous life, saw this happening, right? The negotiations between an insurer, a hospital, and a physician group are some of the most intense and sophisticated negotiations occurring in markets in this country. And the notion that you or I, as a patient, as a person in need of healthcare services, has to be able to track all of that and then be responsible, because my hospital could not negotiate an in-network contract with an ED doctor, so now I'm gonna get stuck with the bill, is the tail wagging the dog, right? That hospital should have the responsibility of saying, if I am an in-network provider for you, you can come to my ED and not get stuck with a hospital bill that is 3 times larger and my cost sharing is much larger, right? That is a tail wagging the dog.
Thank you. So how prepared are Americans for these unexpected expenses? And could you speak on the impact that these expenses also have on individuals' overall well-being?
You bet. Absolutely. And as I noticed in my testimony, that right now, what we know is that more people are scared of hospital bills and healthcare bills than getting sick. I mean, that's where we are as a nation. So there's more harm right now happening in this country in some ways, psychologically, around the cost of healthcare than actually being scared about their health. Okay, and in terms of I'm sorry, I missed the first part of your question.
Oh, I was just saying, how prepared are Americans for these unexpected?
Well, this is another thing we know, is that almost half of Americans, they have less than $400 in savings, right? And so a surprise medical bill for $2,000 means I'm gonna have to miss my car payment, miss my mortgage payment, I'm gonna have to take out of my retirement account, right? When people pay for health insurance, what they're trying to pay for is financial security. To know, I'm doing my part, I'm paying into a system, now I get sick, and now that system takes care of me and makes sure that I don't lose everything I've worked for my whole life because I got sick. And what we know is a surprise medical bill can be a devastating blow on a family that's trying to live that life and be self-actualized.
Thank you, thank you. And now, Mr. Allen. Thank you.
Thank you, Chairwoman, and thank you, panel, for giving us some insight on just how magnified this problem is. And of course, I hear from constituents that surprise medical billing has become a significant concern for Georgia families. The problem is this whole process of healthcare is so complex that you have, if you're out of network or in network, deductibles, and is your doctor in network? I mean, you were supposed to be able to keep your doctor. It's just a total mess, and it needs to be fixed sooner than later. But 2/3 of Americans say they are somewhat worried about being able to afford their own family members' unexpected medical bills. And as we said, these surprises, how does a family deal with it? Ms. Schuman, 22 states have passed legislation on surprise billing. What are the different models that states have enacted, and are there any lessons learned from their approach to this problem?
Thank you. Yes, a number of states have acted to address surprise billing in a number of circumstances, some of which we've discussed here, ranging from purely protecting the patient to requiring, for example, binding arbitration between the payer and provider to resolve that dispute, or in some cases, California, for example, requiring setting a reimbursement that's the greater of 125% of Medicare or the average in-network rate. There are some lessons to be learned from that, but they are limited. They're limited by time and scope. By time, because, for example, the California law just became effective at the beginning of this year, so we really don't know the impact that's having. But I think more critically, they're limited in terms of scope, because they don't cover ERISA self-funded plans, 60% of employer-sponsored coverage. So we don't necessarily know if those same lessons would apply on a national level. And I do want to say, just with respect to Texas, there could be some important lessons there with respect to a binding arbitration or dispute resolution process in terms of a backlog of cases in the Texas system to try to address this through through dispute resolution. They have changed the law, but again, I think we need to be careful of that if we're thinking about employing that on a nationwide level.
Well, certainly, we need to look at these models and see what we need to do at the federal level, because and the other problem is healthcare costs are just accelerating like nobody's ever seen in the country. We've heard a lot about the role of patients and providers and employers in finding a solution for surprise billing. Should hospitals also have a role in addressing surprise billing? In other words, should the hospital know that, hey, you know, you're going to get a bill from, you know, this group or that group? I mean, it looks like full disclosure should be on the agenda here.
Absolutely. Hospitals play a critical role in this. The hospitals are the one with these hospital-based physicians. Oftentimes, those specialties that are integral to being able to operate that hospital and treat patients are not employed by the hospital. They're not in that hospital network. And that leverage, that relationship between the hospital and the physicians that are practicing at that hospital is key and I think fundamental to addressing this problem in a way that works.
We've got about a minute. Many of the patients that receive surprise bills are covered through employer-sponsored plans. What are employers doing? And of course, you know, the business community is trying their best to address this accelerating cost of health care. What are they doing to provide more information and transparency for their employees to help avoid these situations?
Well, thank you so much for that question. And this is a deep concern for employers. And council member companies are taking steps to limit the incidence of surprise billing in the first place through, for example, enhanced communications to their employees about the potential for balance bills, and also provide assistance to their employees who do receive a balance bill in the form of contracting with other entities to try to negotiate that down or providing some sort of legal defense funds. But despite these efforts of employer, the problems still persist.
Yes. Well, thank you so much, and I yield back.
Thank you. Ms. Underwood?
Thank you, Madam Chair. Thank you for holding this really important hearing today. And I'd like to thank our panelists for being here and for your really comprehensive written testimony. I've enjoyed reading through your comments. Like many of us, people in my community in Illinois have experienced surprise billing, and I frequently hear from constituents about their struggles to afford health care, even health care more broadly, when I'm home. And so, according to the Healthcare Cost Institute, in my home state of Illinois, about 15% of in-network hospital admissions resulted in at least one out-of-network claim in 2016. And so my questions are for you, Dr. Hoadley. I'm proud that Illinois has taken a leading role in addressing this issue by enacting consumer protections that you described as comprehensive in your research. Given your expertise on these state approaches, I was interested in getting your perspective on how effectively Illinois has addressed this issue. So first, what are some of the strengths of the Illinois law in terms of its scope and protections for consumers?
Well, certainly one of the strengths of its law is that it does apply to a broad variety of circumstances. They regulate both the HMO environment, the PPO environment, so regardless of the type of insurance. They address both situations that arise in emergencies as well as those that arise in more elective procedures, as we've heard talked about, some of the circumstances where you go in to get a particular elective surgical procedure but might encounter an out-of-network anesthesiologist. So Illinois does have a good law in place.
Great. And so how does the Illinois law resolve disputes between the providers and insurers?
So what they really look to is to try to get the provider and the insurer to negotiate a private amount. There is a dispute resolution option in Illinois. When we last talked to the folks in Illinois, they said that had not actually been invoked. So it was there perhaps as a backstop, but for the most part, things got resolved privately. They did have some concern when we talked to the Illinois officials that there may be instances where consumers get bills sent to them, aren't aware that they don't need to pay them, so don't start the process. And that goes to this sort of point of how do you really make sure it's not the consumer's responsibility to figure out that, oh, by law, I don't actually have to pay this bill. Now what do I do to make sure that happens? If you don't know that, that doesn't really help you. And so what some other states like California has done is to include a provision that says the provider really can't send a bill, and if they do end up sending a bill and the consumer pays it, there's an obligation on that provider to refund the amount that was paid back to the consumer, and that's something we haven't seen in some of the other states.
That's interesting, thank you. As we look to develop this comprehensive federal solution, what lessons do you think we can learn from how Illinois has tackled the issue?
So certainly, trying to do something that's comprehensive is an important part. I think one thing that is also somewhat of a limitation in the Illinois law is that in the non-emergency situations, it limits the protections to a certain specified list of provider types. So, it does cover the emergency room docs, the most common ones that come up, the anesthesiology, the radiologist, and so forth. But it doesn't necessarily address an issue when there's a consulting cardiologist that's called into your case. Or where maybe an orthopedist is called in because you came in with some situation that involved a bone injury. And so, one of the things that other states have done is to make sure that the law applies comprehensive to all types of providers rather than specifying the list of the ones. And yes, they do list the ones that are most commonly come up, but that doesn't mean it necessarily works in your particular case.
Thank you. Speaking of the providers, I was reading in Kristen Link-Young's testimony about the neonatologists and some specific surprise bills that often arise upon the likely early birth of a child and some unexpected out-of-network claims. I just was wondering if you wanted to expand a little bit on that.
Absolutely, thank you for the question. So we've talked a lot about this issue from the patient's perspective, which I think is extremely important, but it's also helpful to think about the issue from the perspective of one of these providers. Once a provider, like an anesthesiologist or a neonatologist, is in the hospital practicing, they will receive a flow of patients, regardless of whether or not they join insurance company networks and regardless of what price they set. So for that neonatologist, once they're in the hospital, they're going to be the neonatologist taking care of those babies, and they have a very limited incentive to join insurance company networks and accept a negotiated contract rate from an insurance company. It's the same dynamic that all of these provider types face, and the key to a solution is to get rid of that set of incentives and instead encourage those folks to come back in network or work with hospitals for their payment.
Well, I'd like to thank you all so much for your expertise, and I yield back my time.
Thank you, Ms. Underwood. Now, Dr. Fox, our distinguished ranking member of the Education and Labor Committee. 5 minutes.
Thank you, Madam Chairman, and thank you for organizing this hearing, and I want to thank all of our witnesses for being here today. It's been very, very informative. Ms. Schuman, I know that surprise billing impacts patients on a personal level. On a larger scale, how often do patients receive surprise bills? Do we have information on
that? Kaiser Family Foundation of Medical Debt found that among individuals who faced out-of-network bills that they could not afford, nearly 7 in 10 of those didn't even know the provider was out of network at the time they received care, hence the surprise. Another analysis of medical bills from large employer plans found that nearly 1 in 5 inpatient admissions included a claim from an out-of-network provider that could result in a surprise bill. Even when enrollees choose in-network facilities, 15% of inpatient admissions include a bill from an out-of-network provider, such as an anesthesiologist.
So does the percentage change based on whether the patient is receiving emergency care? Do we have information about that?
Yes, and for inpatient admissions that include an emergency claim, they're much more likely, 27%, to include a claim from an out-of-network provider than admissions without an emergency room claim, 15%. That's the case whether or not enrollees use an in-network or out-of-network facility.
All right, what about when ambulances are provided?
Well, for ambulance services, the figures are even more alarming for patients in the most dire of circumstances. As Ms. Young's testimony notes, among people with employer-sponsored health plans, 51% of all ambulance cases involved out-of-network ambulances. And according to a recent GAO analysis of air ambulance transports of privately insured patients, 69% were out-of-network.
Okay. So let's talk a little bit about what happens after a patient receives a surprise bill. Are patients able to successfully negotiate down the amount? Professor Hoadley alluded to this in his comments recently, but are they able to negotiate down the amount, or are they forced to pay the entire bill?
Well, generally, a patient does not have much recourse after he or she receives a balanced bill. And that's because state laws generally hold individuals liable for the costs of goods and services received, not just with consumers' goods, but for medical care and that as well. And to that end, providers generally have individuals sign a contract prior to service indicating that they agree to be responsible for all billed charges. And it's these contracts and the related state laws that providers use as the basis for balance billing. Now, in some instances, employers do try to protect their patients from receiving or otherwise having to pay these balance bills by negotiating with the out-of-network provider, but these employer actions themselves are not without cost because employers that voluntarily try to protect their employees from balance bills have increased plan costs because in most cases they end up having to pay more to settle the balance bill, and this gets reflected in higher premiums for all consumers.
Well, let's pursue that a little bit more. Determining whether providers are in or out of network can be confusing. Obviously, it sounds like for plan providers as well as patients. So what influences a provider's decision to participate or not participate in an insurance network, and are there incentives or trade-offs for participating?
This is the key question. And the incentive for a provider to participate in a network is to have access to a volume of plan enrollees because plans are trying to drive patients to a high-value network. The trade-off for a lower in-network reimbursement rate is a provider is going to more than make up for that in volume. But for some of these hospital-based specialists that we've been talking about, they have inelastic demand. The patients are going to come to them anyway. So that incentive is not there. And the market is therefore distorted, and surprise medical bills ensue.
Thank you.
Thank you, Madam Chairman. I yield back.
Thank you, Dr. Fox. Mr. Courtney.
Thank you, Madam Chairwoman, and thank you for your leadership on this issue, which is definitely sweeping the country. It's partly because of some great reporting. Sarah Cliff from Vox has done a great service in terms of a series of articles on this, as well as National Public Radio. Congressman Doggett from Texas has a bill that's pending in Congress that, again, would take the patient out of the crossfire. And as we've heard, a number of states have actually moved forward with legislation like the state of Connecticut, which in 2016 passed a bill on a bipartisan basis, by the way, that, again, at least focused on the question of emergency room billing, which again, took the patient out, set up a standard in terms of reimbursement, and also limited the out-of-pocket loss that would be credited against people both for out-of-network bills in terms of their overall deductibles. You know, again, this committee, which has jurisdiction over ERISA, is exactly where this issue belongs. As I think we've heard, the Employment Retirement Income Security Act preempts state regulations. So the fact that Connecticut or Illinois or other states have done good work in terms of moving forward, again, there is a huge number of employment-based plans that, again, are unaffected by this. And again, I think it's just so important to foot stomp that. And I guess I would just ask Ms. Schuman, again, that, again, ERISA really has to be dealt with if we're going to really have a comprehensive solution for America's patients. Is that correct?
That's exactly right. For the self-funded plans, the 60% of employer-based plans that are not subject to these state laws, like in Connecticut or other states, we have to have a federal solution that addresses ERISA so that we deal with this problem in a uniform nationwide way.
And when we passed patient protections with the Affordable Care Act in 2009, again, it was this committee that really crafted the language regarding pre-existing conditions, lifetime limits, essential benefits, which again removed the ERISA preemption and again set a standard that was universal in terms of all health plans. So again, I think it's, unfortunately, the President's declared war again on the Affordable Care Act. But again, our mission is just to keep, again, using the best information possible, because healthcare is such a dynamic issue, and this surprise billing issue obviously has really popped up that really escaped the Affordable Care Act's scope of patient protections. Again, I'd like to ask Professor Hoadley about the Connecticut law, which, again, as far as emergency rooms, used a different approach than the negotiated process of resolving some of these bills, and again, established a standard which would appear, at least in some respects, to have the salutary effect of having a pretty sort of standard process that can be dealt with, can be implemented in a timely fashion versus a negotiated arbitrated. I just wondering if you could kind of tease out the pluses and the minuses from those two approaches.
Yeah, there are definitely pluses and minuses to the two approaches, and you know, we haven't had enough time on a lot of the laws like Connecticut's and New Jersey's to really gain a longer, richer experience to draw from. But we can look at some of the differences. I mean, what the payment standard that Connecticut and other states use, one of its advantages is that it sets a clear number. It's there for everybody to see. There's sort of no ambiguity. Now, if you don't like the number that it sets, or you think the number that it sets has consequences, so states will vary between using a Medicare-based rate, a rate based on network charges, network allowed amounts, or a standard based on charges. And it makes a lot of difference which of those, because the numbers involved are quite different. In any of those cases, it's a percentage of that standard. So, I mean, it's not necessarily at the Medicare level. It might be, as others have suggested, 125% of Medicare. The advantage of the arbitration process is that it allows the individual circumstances of a particular case to be dealt with. Most states that have used an arbitration process have set it up in a way that really views it as something as kind of a last resort, not something that's going to be used on case after case. And so a combination of when they do adjudicate cases and make a decision, those amounts become part of public information, and so they can be a lesson to others. But simply the fact that there's a potential way to solve a number if you can't get to a resolution actually does create the incentive for the parties to get together and resolve it on their own. They want to avoid the cost of going to that process. So there really are some merits and disadvantages on both of those approaches.
Hopefully we'll move swiftly and make a choice, and because again, this is an issue that can't wait. With that, I yield back, Madam Chairwoman.
Thank you, Mr. Courtney. Mr. Taylor?
Thank you, Madam Chair. And I'll just note, particularly for the Chairwoman, that I consistently voted in the state legislature to address this particular issue on a bipartisan basis in my time in Texas. And it's certainly an issue that we as state legislators in Texas saw as a problem and addressed. Of course, most Americans, over half of Americans are on ERISA plans. So we're talking about the big plan, right? This is really where the show is from a policy point of view. And so one of the questions I had, Ms. Sherman, is just what is, and let me just reiterate, it is so important that we solve this problem. This is a real problem that's affecting people every single day. And I hope that we craft a bipartisan solution in this committee, because only a bipartisan solution can actually go be signed by the president, can be passed the Senate and go be signed by the president. Otherwise, we're just sending another messaging bill, which will have no impact and not really solve the problem. So I'd rather have something that's going to go all the way to the president's desk than something that's going to not get anything done. But Ms. Sherman, in your mind, looking at the state solutions, I know we've had some discussion about different state solutions. What have they done that, in your mind, is a model for us that you think could be supported by Republicans and Democrats get through the Senate and be signed by the president?
Well, thank you so much. And I think there are some lessons to be learned, and maybe drawing from different states and taking pieces of different state legislation. The California state legislation that we've talked about does include a component of capping reimbursement at 125% of Medicare or the in-network rate as a way to, again, cap reimbursement so as not to undermine network participation. Other states that have adopted an arbitration model.
So that's an acceptable solution for you, 125%?
Well, I think
because your original testimony, I thought you were saying we shouldn't set prices,
well,
but it sounds like you are saying
I think there's two, I think our recommendation is twofold and deals with the situation of an out-of-network emergency facility for emergency services different than for an in-network hospital.
Okay.
For emergency services at an out-of-network facility, that means a hospital didn't even contract with the plan, emergency services, that's what I would suggest, that capping it at 125% of Medicare is a reasonable way of approaching that and to foster some sort of equitable competition. With respect to an in-network hospital, that in-network hospital should ensure that providers practicing at that hospital would pay an in-network rate. So the Medicare reimbursement structure is only that I recommended is only with respect to the out-of-network emergency. Otherwise, you go to a hospital, an in-network hospital, in-network rate, contracted rate. And that would remove the disincentive for these specialties, these hospital-based specialties, not to join the network.
Have you seen the legislative support for those two solutions in other states on a bipartisan basis, the way that we've been able to do it? We've not approached it the way that you're suggesting. But what we did in Texas was bipartisan. I mean, everybody voted for it. Or pretty much everybody voted for it. So it was something that we could all agree on. And again, I want to solve this problem here at this level. And so my question to you is that something that you've seen, there's a lot of bipartisan support for it, or did that get kind of caught up in a lot of partisan politics?
We are crafting solutions right here. We're looking at the problem. We're looking at states like Texas, California. No one has come up yet with a comprehensive solution that gets it right and gets it right for everyone. And I think that's what this committee has an opportunity to do.
Okay, and Madam Chair, I'll just reiterate, I voted for every effort in Texas to try to address this issue, because this is a real issue, as you point out. I think we all know this is a real issue. And I just want to entreat you, as the chair of this subcommittee, that you reach out and let's get something done on a bipartisan basis so that it can go through the Senate, be signed into law by the president, and we can address some of this problem. I know we're not going to probably get a perfect solution if it's a bipartisan solution, unlike I'm sure you could draft a perfect solution over on your side, but the problem is a perfect solution that doesn't go anywhere is of no help to the people that we're trying to help. So I'm with you, and I look forward to working with you on this. With that, I yield back.
You got a deal. All right. Thank you, Mr. Taylor. And now, Dr. Shalala.
Yes, thank you very much, Madam Chair. I've always been interested in building on, when states have taken on an issue, building on their experience. And it looks to me like it's the payment standard and the dispute resolution standard that differ between the states. Some of the other elements there seems to be consensus on. So it sounds like this committee has to focus on those two things. And I'm with Mr. Taylor. If we can figure out how to get a compromise somehow. But here's my question, because you've been answering questions about individual states. Has there really been a decrease in the number of out-of-network bills since states have adapted, particularly the comprehensive states? Have these, I haven't seen the answer to the question on whether it's actually worked, particularly in the comprehensive states. I think Texas is sort of a moderate, somewhere in between, but I'm particularly interested in the comprehensive states. My own state, Florida, which is for the most part represented by my colleagues on the other side, has had a comprehensive approach. California has had a comprehensive approach. So could you talk a little about how effective these approaches have been?
Yeah, I can talk about that. It's a really good question. One of the challenges we have is that a lot of these have only been in effect a relatively short time. And it is noteworthy that many of these solutions, I think really all of the states have done this in a very bipartisan way and have brought together, and the ones that have been most successful is when they've really brought both parties and all the different stakeholders to the table. There's been some look at the track in New York, because it's one of the ones that's been in effect a few years now. And I think we're finding, I have colleagues at Georgetown that are taking a closer look at sort of what's worked and what hasn't in New York, and they'll have that report done soon. But what I understand they're finding so far is a general degree of satisfaction, that stakeholders across the spectrum do think that things have worked out pretty well. There's some research evidence that there's been no particular inflationary effect coming out of the process they've used in New York, and so that's an encouraging sign. Florida's had a different approach in for a few years, and then they revised the approach just a couple of years ago, and I have not heard any particular feedback yet from Florida on how well that's played out. California's is relatively new, New Jersey is quite new, and so that's really the challenge in trying to learn the lessons. But I think the overall impression, at least qualitatively, when we interview stakeholders and insurance department officials and others that are involved in this, is that they feel like the solutions they've had have been pretty successful, and then they go back and make adjustments where they find gaps, and maybe that's a little easier to do in a state legislative context than it is in federal legislation, but they've been able to go back in many of these states and make adjustments and try to improve their law.
But it sounds to me like we have to learn from the adjustments.
Yes.
As we're crafting national legislation. I have one other quick question, and that's about air ambulances. I live in Florida. Air ambulances are often out of network. I think the GAO recently said that 69% of the air ambulance were out of network. Have any of you thought about that in particular? Yes, Ms. Young.
Yes, so as you know, this is an acute problem in the air ambulance context for exactly the same reason it's a problem in the other areas of the market that we've been talking about, because there is no incentive for these providers to go in network, because when someone needs an air ambulance, they're going to be picked up by a particular air ambulance, and a patient just doesn't have a choice about the network status. So the solution here is the same as we have been talking about for all other provider types. You need to sort of create conditions that diminish the attractiveness of remaining out of network and encourage these folks to come in network at a reasonable price, or to otherwise sort of get paid an appropriate amount. So by setting a payment standard or otherwise establishing a mechanism by which these folks can get paid an appropriate amount. The other complication with air ambulances, which I think is important for this committee to consider, is that states are generally preempted from regulating air ambulance conduct, and so it's a place where, in particular, you need federal activity. The one other thought that I think is important as we think about evaluating state solutions is, and what states have done so far, is not just whether or not the state law has decreased surprise bills or out-of-network bills, but also what effect it's had on overall healthcare costs. Because you can have a law that sort of makes a lot of people happy by paying more money to these specialties, and we also need to be considering the effect we're having on premiums and overall spending.
Thank you.
Thank you, Ms. Young.
I yield back.
Thank you, Dr. Shalala. Mr. Banks.
Thank you, Madam Chair. Consolidation of the healthcare sector is something that we need to consider when looking at some of the high hospital costs faced by our constituents. A number of government policies discourage a thriving and competitive hospital market, including lack of site-neutral payments at the federal level and certificate of need regulations at the state level. While I agree that surprise billing is a problem that we need to address, it's important that we not pursue policies that encourage even more consolidation in the hospital market, which countless studies have shown drives prices up to unaffordable levels. Ms. Schuman, your testimony mentions bundled payments as a possible remedy for surprise billing. First, can you explain to the committee how bundled payments would look different from the system that we currently have?
Sure. You'd get one payment from the hospital for all of the services that were provided at that hospital. So instead of getting one bill from an in-network facility and the anesthesiologist that was out of network, and you get a different bill from their practice, and the radiologist that did an MRI on you, and they're out of network, you get a different bill from them, a balanced bill, by the way, that, oh, was a surprise you didn't know about. The idea of a bundled service is it's one-stop shopping at an in-network hospital, an in-network facility. So they make sure that when they contract with a plan, they're contracting for a bundled of service, that continuum of care that the patient is going to receiving. And I do think that there is some promise in looking at that, and it certainly does bring hospitals into the equation, and they're a necessary partner, but we do have to have some guardrails around there to make sure that that doesn't further escalate and increase costs and just become a bundled payment of a much higher billed charges, and that it's also indeed a final payment, not a starting point.
I have another question to follow up if you had a quick...
I was just going to say, Congressman, it's such an important question you're asking, which are the unintended consequences of trying to solve this problem. And this idea that by trying to get providers to coordinate and work in networks, you can create consolidation, and then you can really damage competition and price goes up. I mean, it's a very valid concern. In this instance, however, we're dealing with these, what folks refer to as auto referrals or inelastic demand, where these providers are, this isn't a situation in which you have two competitive providers who are operating and now you're bringing them together and you're killing competition. It's an instance where you have these providers who are protected from competition because they get these auto referrals, right? And it could be because when I come in for a service in this facility, the lab service goes here and there's no competition, right? So I think it's a really important question. We are doing a lot of thinking about that at Families. It's a central part of a focus of our work in the coming year. But in this instance, because you're in this auto referral environment with inelastic demand, it's actually the opposite problem. These guys never compete because they can just count on this volume no matter what.
Thank you for that. Let me move on really quick. Because Medicare pays hospital-owned outpatient departments more than independent practices, hospitals have a strong incentive to purchase outpatient departments and clinics. Not only does this result in higher copays and out-of-pocket expenses for patients, it pushes overall costs higher through increased consolidation. Ms. Schuman and Mrs. Young, or the other of you, if you want to weigh in on this too, if we have time left, is it fair to worry that a bundled services model of payment could encourage even more vertical consolidation in the hospital market and further drive up costs, just like the lack of site-neutral payments? Ms. Young?
Sure, I can start. So I think that in this arena, these are already providers that are sort of by definition practicing in the hospital. Your anesthesiologist, your radiologist, they are already delivering the services in the context of a hospital inpatient stay or an emergency department visit. So I think there's less reason to be worried about it in this context than others. I would also add that these provider groups and hospitals typically already have sort of linked financial relationships. So you're not creating a new dynamic or a new set of incentives here.
Ms. Schuman, I got 20 seconds left.
Yes, I would just reiterate those same comments and want to do, and also the importance and advocacy for site-neutral payment reform as a way to remove some of the disincentives to a lack of competition and consolidation. And as I said before, I think the bundled payment model could have some promise here, but we need to include the appropriate guardrails.
I wish I had more time for the rest of you, but my time has expired.
Thank you, Mr. Banks. Mr. Morrell?
Thank you, Madam Chair, for holding this very important hearing. I just want to note that during my time in the New York State Assembly, tackling the issue of surprise billing was a priority for me when I served as chair of the Insurance Committee. And then as Majority Leader, I'm very proud that our work culminated in the bipartisan passage of New York's groundbreaking out-of-network consumer protection law. And I just want to take a moment or two to describe what we did and then to get some feedback from the panel This law took effect in 2015, so it's been on the books now for several years. And the law created transparency and a simple system for resolving out-of-network medical bills, which we believe makes life easier for every New Yorker that would otherwise be hit with costly bills that would devastate their families. In addition, and this was really important to us as we were drafting it, the law did not, in my view, create a perverse incentive for providers to move out of network because they would get a benefit financially from doing so, and we avoided that. In New York, hospitals, clinics, physicians provide patients with public information regarding standard charges for medical services and insurance plan participation, and the law allows patients to be smart consumers of medical care, reducing the possibility in the first place of being hit with an out-of-network charge. But even more importantly, the law provides a mechanism for providers and insureds to come together, resolve out-of-network charges without stress or additional costs to the patient. In cases where patients received emergency services at an out-of-network facility, the patient is held harmless, paying the same exact copay or deductible as they would as an in-network emergency department. And even patients without insurance or those with non-state regulated insurance are eligible to file a dispute for an emergency services bill. So those self-insureds and other plans covered by ERISA, not regulated by the state. In addition to surprise emergency room bills, New York patients are protected when a non-emergency provider sends them an unexpected bill. And rather than being forced to cover out-of-network costs from their own pocket, patients do an assignment of benefit to their provider, who then has to negotiate a reimbursement amount with their health plan. So again, the consumer is taken out of it. In the rare cases that negotiation is unsuccessful, an independent arbiter is able to make a determination to set a reimbursement rate within 30 days. I think it says a lot that in most cases arbitration is not necessary. I heard yesterday, and I got to verify this, but roughly 800 arbitrations out of 7 million claims information. Instead, insurers and providers can reach an acceptable deal without the consumer having to devote any more time, money, or any more headaches. The laws help settle about 2,000 billing disputes and protecting those New Yorkers from potential harmful medical debt. To my colleague, Ms. Shalala, I just want to note, my data shows that out-of-network bills in New York has declined 34% since the law took effect in January of 2015. In addition, prices charged by in-network emergency room doctors have dropped by 9%. So it's rare, but in New York, and I've talked within the last several days in advance of this hearing to insurance plans, consumers, and healthcare providers, and they all agree that the system has changed for the better. Frankly, there's not much that those three groups necessarily agree on. So to any of our panelists, and I apologize, this is sort of a long intro to this, but I'd be curious as to your observation of New York's law, which has been in place now 3+ years, and whether or not there are things that New York has done that could be done better in your view, and what barriers there would be to putting those protections at the federal level. And I ask each of you to quickly just...
So I'll be quick. I think the strengths of the New York law are that it is very comprehensive and it's clear to stakeholders what the process looks like. The potential reason for concern is that I think that because the New York law gives guidance to arbiters that's based on charges for services, it has the potential to be inflationary over time. There's a concern that a lot of observers have about how the New York law may evolve, and would encourage folks to think carefully about that.
And the direction we use is that 80% of the usual and customary charge is determined by the Fair Health Plan?
Right, so it's 80% of charges. The problem with charges is they're not market determined. So it's a bit like saying sort of, the 80th percentile of your wish list to Santa. Over time, there's no constraint on what you ask Santa for, so it can be inflationary over time in ways that we should think carefully about.
Gotcha.
Yes, I want to just raise that same sentiment and the concern that an arbitration model that in any way uses a reference to billed charges is just going to build in those same perverse incentives that we're trying to address.
I do note, in response, I'm sorry, let me just do this, Madam Chair. I'd ask unanimous consent to submit the following letter from the Health Association of New York State, which highlights the success of the comprehensive legislation in New York to eliminate surprise billings and the benefits it's created for New Yorkers.
Without objection.
Thank you.
Thank you so much, Mr. Morrell. Mr. Watkins?
Thank you, Madam Chairwoman. Nobody likes going home, opening the envelope, and finding a surprise medical bill. The lack of network and cost transparency seems to be a problem. As Congress members, where should we start looking to find a solution to this? Are there state law or state law models that we could adopt at the national level? Ms. Schuman?
Sure, happy to talk about that. And I think we can look to the state models as examples. As we talked about before, they have limited application in the sense that they don't include ERISA plans. So that's a large swath of people that aren't going to be protected by state law. So, and also some of them are rather new. So we don't really know what their application over time is. And just the discussion we were just having, for example, with respect to New York and the arbitration model there, I think we need to guard against any sort of structure in an arbitration model that would use billed rates as direction to the arbitrator, because that would, I think, just fuel and further incentivize out-of-network providers to stay out of network and raise their bill charges. So we've got certainly lessons that we look to the states, but recognizing again that to get at the problem in its root and in a uniform manner, we need Congress to act.
Thank you, Ms. Schuman. Mrs. Chairwoman, I yield my time.
Ms. Strahan.
Thank you, Madam Chairwoman. Thank you all for your testimony today. It's been very helpful. My father was an iron worker before he was diagnosed with multiple sclerosis. MS, as you all know, is an unpredictable and disabling disease of the central nervous system. And for those living with a chronic and progressive disease like MS, surprise billing adds undue stress and financial uncertainty. For instance, an individual living with MS might go to an in-network facility, but be seen by an out-of-network neurologist. So, Ms. Young, we all have heard stories from family members and from our constituents who have received surprise medical bills, even after carefully researching their provider networks. How can we best protect these individuals who suffer from chronic diseases like MS from surprise medical bills in all settings of care, including those non-emergency situations?
Thanks for that question. So there are two key principles in designing a solution. The first is to take patients out of the middle. As we've talked about, it's essential that patients not be responsible for these balanced bills and not have the burden placed on them to navigate the system. And the second principle in designing a solution is to create a system that doesn't drive up overall healthcare spending. With a group of scholars at the Brookings Institution, we have recommended two potential policy solutions. One we call billing regulation. It's something that we've talked a lot about this morning, where we would use policy to set a cap on what providers can get paid out of network. Again, our goal here isn't to determine the ultimately correct commercial payment rate. It's just to end the lucrative out-of-network billing option and instead restore sort of a more normal set of market incentives for these folks. So that's one option, and that's what we see in all states, or vast majority of states that have tackled this problem. They use a model that looks like that. The other potential approach is something we've called contracting regulation. You've heard from others under the name bundling, but this idea is simply to get this group of providers out of the business of billing patients directly at all. That's a big step. It's a big change from the way these services are billed today. But it does have analogs in other parts of our healthcare system. It's how nurses and nursing services are paid and billed today. So I think it's an area worthy of exploration.
Great. Thank you. Thank you for that. Mr. Isasi, the workplace is the single largest source of health coverage in the United States. According to the Kaiser Family Foundation, about 152 million Americans, which is about half of our non-elderly population, are enrolled in employer-sponsored health insurance. So I think it's critical for us to highlight how surprise billing impacts employer-sponsored insurance specifically. How common are surprise bills among enrollees in employer-sponsored plans?
Yeah, well, what we know is the research is very clear. They are as common in employer-sponsored coverage as they are in insured or individual plans. There's no difference. It happens just as often.
So no difference between individual and group market?
Exactly, exactly.
How should the committee proceed then in order to fully protect workers from your view?
Yeah. Well, I think the principles we're hearing, there's such broad agreement on the panel and amongst all the members. This is really clear. As we talked about earlier, this is a situation in which the tail is wagging the dog, right? When you enroll in health insurance and your hospital says, this is our network, you get to go to that hospital and get services and be in network, right? You don't get to be surprised because your hospital decided, you know what? We're not going to negotiate with the ER docs. They'll be out of network. Or we're not going to negotiate for laboratory services, right? So this principle that the entity that should bear the risk of building the network and paying for and making sure those services are part of the contract is the hospital, the payer, and the provider, not the consumer. So consumers taken out of the equation is a really important one. The second one is this idea that transparency is not nearly enough. We all know this. We know this from our experience. We know this from the research. The healthcare sector cannot provide real, actionable information to consumers at point of service about what their network looks like, what their costs are. There's lots and lots of data about this. And so you can't put the onus on the consumer to just simply figure out what the price is or whether or not they're in network. I think the third is this idea that patients, this is not just about emergency services, right? It's about ancillary services that can occur without you even knowing. Right. So if you go get surgery, your surgeon's in network, your hospital's in network, but your anesthesiologist is not. That can't happen either.
Right. Well, great.
Thank you.
Thank you so much. I yield back.
Thank you, Ms. There are no more members here. Anyone else? Questions? Wow, okay. I want to remind my colleagues that pursuant to committee practice, materials for submission for the hearing record must be submitted to the committee clerk within 14 days following the last day of the hearing, preferably in Microsoft Word format. The materials submitted must address the subject matter of the hearing. Only a member of the committee or an invited witness may submit materials for inclusion in the hearing record. Documents are limited to 50 pages each. Documents longer than 50 pages will be incorporated into the record via an internet link that you must provide to the committee clerk within the required time frame. But please recognize that years from now, that link may no longer work. Again, I want to thank the witnesses for their participation today. Thank you so much. This was fabulous. What we have heard is very valuable. Members of the committee may have some additional questions for you, and we ask the witnesses to please respond to those questions in writing. The hearing record will be held open for 14 days in order to receive those responses. And I will guarantee you will have lots of questions. Everyone seemed to have run out of time. I remind my colleagues that pursuant to committee practice, witness questions for the hearing record must be submitted to the majority committee staff or committee clerk within 7 days. The question submitted must address the subject matter of the hearing. I'm now going to ask the ranking member, our distinguished Mr. Wahlberg, for his closing statement. Mr. Wahlberg.
Thank you, Madam Chairwoman, and thank you for leading this hearing today. It's something that I think a lot of us have looked forward to as we've begun to hear more and more of the problem, that it's not just my situation or yours. It's running rampant at this point in time. It's impacting our employees. It's impacting our employers. It's impacting our healthcare providers, our insurance industry. But I think what came out today to me most importantly was that the number one concern we need to address, and I think in unanimity here on this panel as well, we believe it's the patient who has the need at the moment seeking the care from probably the best health care opportunity in the world. And yet some of the highest costs that continue to be there because the system is literally confused, if not broken. And so as I've listened today, Madam Chairwoman, I think we can come to an agreement. And I think the fact that we have people here on this panel, this committee, who have done yeoman effort in their own states to come up with solutions, I think we have a head start in understanding some of the pitfalls we can stay away from, some of the benefits we can go directly toward, and ultimately a solution that indeed will be a compromise, but a compromise that is a long way ahead of where it could have been had we not had the expertise or the experience involved. In the end, with a society that is not only intent on having health care available, when we do our effort, our research, we find our physician that's in network, our hospital that's in network, and we think we have it all done for ourselves, we need to make sure that that is the case. But I think also, let's not forget the fact that we're a mobile society. We travel all over. And one of my passions, indeed maybe my only vice that I'll admit to, other than fly fishing, is motorcycling. When I travel around the country on my motorcycle, if something perchance would happen, I want to make sure I'm taken to a hospital, hopefully not by a helicopter, or hopefully not by even an ambulance, but if I am, that I'm cared for. And ultimately, in this great country, I'm not put into a situation that's financially impossible as a result of taking the care that's good care, but in a place that happens to be out network. So I commit myself to working with you, Madam Chairwoman, and appreciate your efforts on this behalf, and hopefully we'll come to a conclusion sooner rather than later. I yield back.
Thank you, Mr. Wahlberg. We're going to work towards that goal together again. Okay. I now recognize myself for the purpose of making my closing statement. Again and again, I would like to thank the witnesses for providing their testimony today. This has been fabulous. This hearing is the first step in what I hope can be a bipartisan conversation as we work to develop a solution to the challenge of surprise medical building. As the Committee of Jurisdiction over employer-sponsored health coverage, we have a crucial role to play in developing comprehensive legislation to address this problem. Our witnesses' testimony will prove invaluable as we move forward. We heard from Ms. Young about the prevalence and impact of surprise bills, as well as some potential ideas for solutions to this problem. We heard from Ms. Schumann about the perspective of large employers regarding surprise bills. We heard from Mr. Asasi about the devastating impact these bills have on consumers, as well as some key principles that should guide us as we look forward towards reform. And we heard from Dr. Hoadley about the innovative solutions that states have taken to protect consumers from surprise bills. As our witnesses have made it clear, it is up to Congress to move forward to comprehensively address this issue on behalf of our constituents. I look forward to continuing this process in the weeks and months ahead. I thank my colleagues for an informative and productive discussion, and I yield back my time. If there is no further business, without objection, the committee stands adjourned. Thank you.